icon in the around the chat section. You can actually click that and you can either give it a thumbs up or a thumbs down, or let me know that you can actually hear me clearly. I have one person. I'd like to get a couple more. Okay, that completes the audio check. I'm just going to go through some introductory slides here. And I won't be turning the video on yet because I don't think I'd like to scare you this early on in the presentation. I'll be making the screen larger in size for the PowerPoint presentations that are about to become. Just some pictures from one of the previous events that we had. Okay, I'm just going to temporarily turn audio off and switch to another presentation. We'll be back in just a sec. Ladies and gentlemen, we'll be starting in the next 1 minute or so. Still on. Hi, good evening, everybody. It's Bill Hughes here from Core Cardiology. Thank you for coming out tonight. We expect about 80 to 90 people in total between in-house and the webinar. We're going to do something a little different tonight. In addition to the musicians, we have local musicians, Weber Brothers, coming in at the end to play some music, and our guest, Jeff Healy, is going to play with them. So if you want to stick around for that, for a cup of coffee or an extra glass of wine and for some music, you're welcome. So tonight, I'm going to do part 2 of the ASA for primary prophylaxis, which we started back at the end of January. And just to remind before we start, we have great support from Bayer, Servier, and BI, unrestricted grants to help support this series. So can you get us full screen?
You're there.
Okay, great, thank you.
Spacebar.
So this is part 2 of Father Knows Best. To tell you what. In our previous talk, we said before you started or did stop the ASA, you had to think about asking yourself whether your patient looked like a patient from the studies that recently published in the journal in October of 2018, or looked like something else, i.e. an old nurse. Well, nurses are relevant because the nurses study was one of the key things that led to a belief that primary prophylactic ASA was helpful in preventing vascular events. Cuckoo's Nest was filmed in 1975, so if Nurse Ratchet at that time had been a newly minted nurse, just now we would be asking ourselves, should we give her aspirin or not? And we still know that a lot of cases, physicians are telling patients that they don't need it anymore. And that might be true, but it might not. So what I'm going to try to do tonight is separate the wheat from the chaff, such as we know it, and try to get to a point where we can decide what to do, at least in the interim, until further information comes forward about primary prophylactic ASA. So as I was thinking about how to do this presentation, I thought, well, why not write to J.J. McNeil in Melbourne and ask him to see if he could clarify for us the whole issue. He did and he didn't. So I told him that my observation was that in a lot of cases, family physicians were stopping ASA in patients who had what I consider to be fairly high risk, and oftentimes weren't considering or discussing whether there was hazards in stopping the aspirin. So I asked him these specific questions. Is there a threshold for not stopping ASA or starting? For example, an FRS of 20%, 30%, known proximal coronary disease, heavy plaque burden, known PAD. And I finished my query by saying, surely not all the elderly are healthy. He replied, and this is really important, first step, is that 90% of the people in Esprit were aspirin naive. And so his interpretation of his own data is that for people who are established on aspirin, there's not sufficient data to stop it. Number one. Number two, he believes that his data is strong, that if patients 70 or over who are aspirin naive, and I've included the low risk in my parentheses there, that starting aspirin is not necessarily helpful, potentially harmful. My belief is that the cancer risk will turn out to be not borne out by other investigations, but nevertheless, he felt that there wasn't enough benefit to warrant it in that group. He makes reference to their forest plot, so they're doing a lot of sub-analyses, so I expect that there will be further publications that will help us better interpret and understand this data, but this is what we have at the moment. I thought his paragraph here was interesting, where he refers to the fact that Esprit should be seen as a lighthouse in his clinical uncertainty, not meant to necessarily apply to every situation. And the kicker was this. They were disappointed, of course, that they didn't have a greater effect. But he said I wish it could be more definitive, but we are still struggling with what it all means here. So this is the guy who wrote the paper. They don't know what to do about their data yet. So I'm going to try to tell you what I think we should do until there's clarity. Bearing in mind that the U.S. Preventive Task Force still has a recommendation for ASA, both for potential prevention of ascending colon cancer as well as vascular protection. I challenged you last time to read the editorial by Paul Ridker in the New England Journal. I don't know if you actually did that. But I reread it a few times myself, and I find it really disappointing. I think it was an opportunity to give guidance, and he didn't. So I'm going to. So I'll give you some do's and some don'ts. I'll try to keep it as simple as possible. And it starts with this. Don't stop ASA in patients who are established on it. That's J.J. McDeal. This is my addition. Unless they were started on it at age 70 or later with an FRS of less than 15%. It will be reasonable, I think, to stop aspirin in those patients. Don't start ASA in patients greater than or equal to age 70 with an FRS less than 15%. I would say do start ASA or consider it in patients who are not Esprit-like, and I'm going to spend some time describing to you who's not Esprit-like with an FRS of greater than 15%. So who doesn't look like an Esprit patient? And remember that in Esprit, the placebo group had an incidence of important vascular events of 11.1 per 1,000 patient years. So if you move the decimal point across, that's 1.1 for 100 patient years, or 0.11 for 10 patient years, which is the equivalent of 11% FRS. Today I saw a man in my office, and this is the screen grab from the Best Science FRS, which I encouraged you to look into and get to spend some time with. He's 44 years of age, a smoker, diabetic, hypertensive, on BP treatment, and he has pretty good looking lipids. He's actually on a Torva 20, but he has a very bad family history. His father had an infarct at age 41 and his sister had an infarct at age 33. So his risk is calculated at 36.3%, just to the right there, the lower panel. And with the Best Science FRS, you can select interventions and see how they impact risk. So selecting high intensity statin, which is highlighted in blue in the center, that reduces 36 to 23. Adding ASA reduces 36 to 31. So what did I do today? Today I increased his atorvastatin from 20 to 80. I put him on aspirin, and I arranged for a blood pressure monitor, and I expect will intensify his blood pressure therapy. So those are the things that have the potential to impact his outcomes. And he's clearly not an Esprit-like patient. He doesn't have an 11% 10-year risk. He has a 36% 10-year risk, even though he's already on statin drug. This is a patient I presented to you at part 1 of this talk, a 56-year-old woman who's a smoker, hypertensive, in spite of therapy, statin intolerant, and has an FRS of 84.3. That's a patient whose family doctor actually stopped her ASA on the strength of the Esprit study, which is a different age group, different risks. And so I would submit to you that we really have to assess each patient individually, and I restarted her ASA. I want to draw your attention in particular the connection between peripheral vascular disease and coronary disease and vascular depth. This is from the recent edition of Brunwald in 2018, the newest edition of the Bible of Cardiology. And in the chapter 64, which deals with peripheral arterial disease, there's, I think, quite a good coverage of this issue. So what they say is that angiographically significant CAD occurs in 60 to 80% of patients with PAD, and between 50 and 25% of PAD have both coronary or carotid disease, up to 62% actually, and the predictive specificity of PAD of an abnormal EBI for major vascular events is 90%. So if you have a patient in your practice who has peripheral vascular disease and you're not treating them with all of the agents that can impact and improve prognosis, I think that's a hazard. This graph just serves to illustrate in the center portion, 1.0 to 1.1 is the normal ABI. If you get down to an ABI of 0.6 or less, there's a hazard ratio of 4, huge difference, both men and women, in terms of all-cause mortality. So this is an extremely important risk factor that we need to pay attention to and often don't. So here's my list of non-Esprit patients. This may change. There will be sub-analyses of Esprit, and there'll be more commentary and other editorials, I'm sure. But at this date, here's what I'm going to do. If somebody has an FRS more than 15%, I'm going to ignore Esprit, because those patients Esprit were extremely low-risk patients, exceptionally low-risk patients. If somebody has PAD with symptoms, I'm going to treat them with aspirin prophylaxis, or if they have ABI less than 0.85 and are asymptomatic, I'm going to treat them with aspirin. If they have known coronary disease, and I don't care how you know it, whether you know it from a cath, whether you know it from a CT that describes significant coronary calcification, whether you have an abnormal stress test, I'm going to treat those people with aspirin. If they have a known significant plaque burden, and that's an area where we need to have greater definition, and I encourage you to come to the 6th and last of this series with Dr. Matangi in April, who's done a lot of original research on this about the importance of assessing plaque and plaque burden. Even if they have a low plaque burden, if there's an ulcerated plaque, I treat everybody with aspirin. Ulcerated plaque is a high-risk observation, regardless of the actual total plaque burden. And I threw this one at the end, all secondary prophylaxis, because unfortunately, some people are forgetting that their patients actually have an established vascular diagnosis. So for example, recently I saw a patient who had a remote coronary event in the 1990s who did have coronary disease. It was lost in the midst of time, and somebody stopped their aspirin. So at this point, at least, no one contests seriously that secondary prophylaxis is in question. Everybody agrees still at this point that ASA for secondary prophylaxis is absolutely indicated. So I'm going to stop with that. I hope I've given you some clarity, some landmarks, some ideas to help you work through this. I expect that things will change. I expect that Professor McNeil and his group will issue more papers as they do more detailed analysis, and this may help guide us further. But I think as of today, this is the guidance that I would recommend to you. I would recommend you join us in 2 weeks for Mike McDonald for heart failure and diabetes. And if anybody has any questions about the ASA for primary prophylaxis, I'd be glad to take them now before I introduce Jeff. John.
So identifying, for example, on the McDonald CAT scan, aortic calcification, would that place them in valid and established?
So that patient has vascular disease.
Okay.
So there's no doubt that they have vascular disease.
Secondary prevention.
So
remember the group.
So yeah, sorry, apologies. Thanks, Doc. So what John had asked about is whether incidental findings, as they're often reported as incidental findings on imaging, for example, is calcification of a tibial artery or the aorta or plaque is seen. So that defines vascular disease. That is the disease of interest. So it's no longer a question whether the patient has vascular disease or not. The question is, what do you do about it? So Dr. Matangi will help us with that when he comes with the vascular imaging. But my own approach is this. If somebody has an FRS that is less than 15 or less than 10, but they've got definable plaque or coronary calcification or something that identifies the presence of atherosclerosis, I treat that as a doubling of the risk from the FRS, which would put you in over 15%, which would make it a treatable case. Now, it's true that in a study of 19,000 patients who are 70 or more, there's going to be all kinds of patients who have vascular disease. The problem is, they didn't do a study where everybody had vascular disease. And that would make a difference, because if you use that as your deciding point, you're not treating the other patient who doesn't have vascular disease. The other thing that where I think the whole ASA for primary prophylaxis thing fell down a bit is there was no clopidogrel arm. And clopidogrel is somewhat superior to ASA for monotherapy. And so we just don't know whether or not, had there been a clopidogrel arm, that there would have been sufficient benefit to look at this differently. Jeff will have some opinion on this as he's an expert on it. But so that's how I look at it. It may be I may be proven wrong in this, but I think that I really think that the Ridker editorial was weak and lame. There was an opportunity to give guidance to physicians in practice, and he didn't, because it's causing a lot of difficulties for people. People are struggling to know what to do. So I hope that the guidance I give you tonight will get us through at least for a foreseeable period of time. We may revise it as we learn more, but I think it's a working definition for what to do now. John?
Bill, I was in Boston at a meeting in the fall, and they were really adamant about using chewable aspirin rather than coated. I think the concern may be the absorption of coated aspirin.
Huh, okay.
So the first half of my question is, do you know whether the aspirin in these studies was coated or chewable? The argument could be that if there were a lot of them were getting coated aspirin, they weren't getting aspirin at all.
Okay, so Dr. Reeser has raised the question of whether coated aspirin versus plain would have had a different outcome, and they don't describe in the I'd have to go back to the paper, John, but in the abstract it didn't specify. It was 100 milligrams of aspirin versus placebo. Okay. Jeff, do you have an opinion on that?
I mean, often it's open, right? Like when we do studies, you're dealing with multiple countries in a study this size, and there'll be regulatory. Okay. Yeah, there'll be regulatory specific things. So it might be 80 milligrams in one country, 100 milligrams in other countries, but usually it's unspecified.
I think in Esprit it was 100 milligrams for everybody, but I don't know if there's coated or not. So that's a really good question. You know what? I'll send Professor McNeil another email and ask him. John, follow up.
The follow up is there was an abstract in the last year that suggested that aspirin needed to be dosed by weight.
Yeah.
If you're over 70 kilos, 81 milligrams didn't cut.
Yeah.
So could that be a second reason why aspirin didn't work in these studies?
Yeah. So Dr. Reeser's asked a secondary question, which is whether the one-size-fits-all dose of aspirin is actually appropriate, and the concept that patients over 70 kilos might require a higher dose. It's interesting because we reflect back on the original research on ASA John Cairns did when we were stuffing 650 QID into patients in the ICU, and there was no doubt about blockade of prostacyclin. So that's a good question, John. I don't know the answer to that. But I think that these are undoubtedly questions people will be asking as they try to interpret how to respond to this Esprit data, which Professor McNeil acknowledged himself, they don't even know how to respond to. Jim?
Sir Bill, a positive result on a carotid screening obviously would fit into the artery disease and would warrant ASA.
Yeah, so Dr. Bond is asking whether the presence of carotid plaque a lot about detail of plaque, but generally speaking, because many labs don't report the detail of the plaque other than presence or absence, my personal approach is yes, that is vascular disease, that is atherosclerosis, and unless there is a reason not to, I would ordinarily start that patient on ASA. Nasser?
They don't do the screening for the general population of the peripheral vascular disease. By the time we diagnose diabetic patients or diabetes, most of them, they have a peripheral vascular disease, say in 40s and 50s. So it's an old philosophy, as soon as you have 40 or 50 years of age, you start taking the aspirin. Because we just cannot really screen everybody. It's a little bit difficult, but we know these people, the incidence of the diabetes is very high. So if the 40, 50, say 50 years of age, shouldn't be taking aspirin?
Yeah, so the question that Dr. Syed is asking has to do with the prevalence of vascular disease in the population before age 70. So what we know is from the carotid studies we've done with many, many thousands of patients, is that in this area, by age 40, between 70 and 80% of men will have definable disease in the carotid, and by age 50, 70-80% of women will have definable disease in the carotid. All that Esprit is telling us is that if they make it to age 70, that starting aspirin at that stage isn't necessarily helpful. I don't think it changes anything about how I'm going to approach vascular disease in younger people. The earlier they are in their life that they have it, the more concerned I am about it. So I'm going to still treat those people with aggressive lipid therapy, with ASA, probably ACRB, periodic ischemia testing. That's going to be my approach for those people. The younger they are that they have the disease, the more concerned I am. So I'm going to do everything I can that I think could be helpful to them. All Esprit is talking about is 70-year-old patients and older at the time you start the therapy. And J.J. McNeil himself says he doesn't think their study is sufficient reason to stop the therapy if it was started before age 70. Okay, so I hope that gives some clarity, at least for a period of time until we know more. And we'll move on now to the second.
Do you want to check if there's questions from the editor?
Oh, yes, I'm sorry. Apologize, Don. Good thing you're here. So those of you who are on the webinar and have sent in any questions?
Nope, there are none.
Okay, no questions from the webinar. Okay. All right, great. So it's my pleasure now to introduce friend and colleague Jeff Healy, who is an electrophysiologist. He's a researcher at McMaster University. When I was at McMaster, the research was primarily platelet-based. But what happened in the subsequent years was because the platelet trials became so large, McMaster became one of the leaders in coordinating worldwide collaborations with tens and hundreds of thousands of patients. And through that, naturally developed through Salim Youssef, the Population Health Research Institute, where Jeff is a key player. And his particular interests have been around atrial fibrillation, how to detect it, how to determine if it's important. And we asked him tonight to talk about the issue of silent atrial fibrillation, the threat that it poses, and to give us some guidance on how hard we should look for atrial fibrillation in various patient groups, including those of otherwise unexplained stroke. So Jeff, if you just step up, great to have you here.
Hey, thanks. Thanks, Bill.
Don's going to get you into full mode, Jeff.
I think that's me. I have my radio face for TV here.
That's definitely it.
So anyway, I appreciate the invitation. It's always a pleasure to come up. It's a really great, medical community you guys have, and Bill and Jennifer play such a key part of this, and it's really quite nice to come up. So I'm going to teach. We teach about what I do on the research side and the clinical side, which is atrial fibrillation, why this is important for patients with implantable devices, but then get into a much more interesting and broader issue about how this is important for patients even out in primary care. And it's cool to see so many primary practitioners here today, because I think this is relevant. That wasn't good.
Was that the space bar?
Yeah, I thought you said the space bar was good. All right, so I always like presenting a clinical case as well. I think that's a good way to start. So here's a lady from our pacemaker ICD clinic. She's 76 years old. She's utterly asymptomatic. She had a remote MI a number of years ago, low ejection fraction despite so-so medical therapy. You can argue that's not actually really good medical therapy. But at any rate, she got a prophylactic ICD. She's had no heart failure, and she comes in for a routine check. Everything's great with the device, no VT shocks, but what you see there are short-lasting episodes of atrial fibrillation lasting a few minutes, a few seconds, and the longest one being just over 2 hours. So the question is, what do you do? So just show of hands, who treats that? So she has a few episodes. This is over 3 years of nonstop 24/7 monitoring. Okay, so who doesn't treat it? Okay, so split decision, maybe 60-40. So that's good because, as was mentioned in the last case, I don't really know what to do there either. This is different than finding ECG-detected atrial fibrillation, and I'll show you why. First of all, what is atrial fibrillation? We can recognize the ECG. It's irregular. There's a waving baseline. We know that this is associated with a 4- or 5-fold increase in the risk of stroke if you have it. But what were they actually studying in Framingham and these other studies? These were studies where patients came in, they had 2 ECGs a year, so about 12 seconds of ECG monitoring. If they were in atrial fibrillation on either of those ECGs, they were defined as having AFib. If they weren't in atrial fibrillation at this time, they didn't have AFib as far as Framingham was concerned, even though, as I'll show you, a large number of those patients actually had the disease. So we're talking mostly about persistent and permanent atrial fibrillation when we think back to Framingham and the risk of stroke associated with that. The clinical trials that Bill was alluding to that got done in Hamilton and across the world, studying warfarin, studying new oral anticoagulants in patients with atrial fibrillation, these were also done primarily in people that were in atrial fibrillation all the time. So 70 to 80% of those patients were in atrial fibrillation permanently, or had persistent atrial fibrillation. And to get into those trials, and many of you recruited to those trials, if you had paroxysmal, you had to have 2 or 3 episodes in the last 6 months documented by an ECG. So fairly high burden. So I'm just going to make the point, much like the vascular disease, you have proximal left mainstem disease we talked about earlier, and then you've got an asymptomatic plaque. There's a spectrum of disease severity, and in the case of atrial fibrillation, this is expressed by the spectrum of burden. That woman in the clinic, her actual time during the year where she's in atrial fibrillation is less than 0.1% of the time, less than 0.01% of the time. And her burden is a lot lower than many of the people presented in these clinical trials. So back when I was in training, also in Ottawa, like some people here, we had great new devices which could detect this. And so these were monitoring 24/7, 365, picking up all short episodes and making a nice little picture and logging when it started, when it stopped, how fast, and all these typical things. So we could really tell what was happening in people. And we were picking up a lot more atrial fibrillation than you would otherwise have seen. We coined this term subclinical atrial fibrillation. It's asymptomatic AFib, and I'm going to talk about it later. But it's not just asymptomatic, because symptoms probably don't matter very much, if at all. But this is the type of AFib you pick up short-lasting, minutes or hours, picked up only with long-term continuous monitoring. So again, I'll make the point, if you find 6 seconds of AFib on an ECG done once, that means something. If you find 6 seconds on an ECG with continuous monitoring for a year, that's a different entity. And I think I'll show you data why I think that's true. So we did this study where we took patients with pacemakers, no history of atrial fibrillation. Everybody's older, over 65, and has a history of hypertension. And after the implant of the pacemaker, within 3 to 4 years, almost half of these patients had 1 episode lasting 6 minutes or more. So half the people at our pacemaker clinic have these short episodes. And so that was a problem because we didn't largely do much about it. We had warfarin back in the day. We were very reluctant. Maybe not in Peterborough, but where I grew up, if you owed money to the electrophysiologist in town, you hid out in the pacemaker clinic because that's the last place you'd ever find them. And so we largely just walked away from this, but we knew it was a common problem, and so we did this study. What we found is if you had subclinical atrial fibrillation lasting at least 6 minutes in duration, this was associated with a significant increase in the risk of stroke, but this risk was not 5 times higher like it was in Framingham. It was 2.5 times higher. And the rate of stroke in absolute terms, under the red circle there, was a fraction of what we had anticipated when we designed the trial. So it was, yes, a risk, but it was a much lower risk than we saw in earlier trials of atrial fibrillation. We're thinking about calling this AFib light, but we netted out on calling it subclinical atrial fibrillation for the reasons I mentioned. When you compare it to the orange bars, these are people in atrial fibrillation cohorts broken down by the old CHAD score. Those are the CHAD-specific stroke rates per year in orange, and the patients in white are the patients in our pacemaker study who had subclinical atrial fibrillation. So yes, it's higher than the blue bars, who are the people that don't have atrial fibrillation, but it's a fraction of what we see in clinical practice. So, back to that standard thing we do as doctors, balance risk versus benefit. Right here, we have an issue which causes an increased risk of stroke, but the absolute level of that risk is lower than what we're used to. So that's my first point. What does burden have to do with it? So if you have 6 minutes or you have 6 hours, what's the difference? Well, the American study, like ours, called TRENDS, they took patients and broke them into 3 groups. No atrial fibrillation. You had subclinical atrial fibrillation, but less than the median value for burden, which was 5.5 hours maximum burden in any day over the preceding month, so 5.5 hours of AFib, and then more than that. And what they found is if you had subclinical AF, but less than 5.5 hours per day, or in the maximum day in the preceding month, the risk of stroke there is identical to if you had none. And if you had subclinical atrial fibrillation more than that, your risk was increased, but again, it's only a 2.2-fold increase, not 5 times, and it's really of borderline significance in their trials. So it's still, is there a threshold above which you should consider treating or not? And then one of my colleagues in the Netherlands looked at our data from ASSERT, and I think this really kicked the ball forward a little bit. These are all patients with continuous monitoring, and we reclassify them every time they have an episode. What's their longest episode? Is it 6 minutes, 6 hours, 24 hours? Long story short, when you get to the gold line, this is having an episode lasting at least a day. So episode lasting at least a day. Here the stroke risk is about 5% per year. This is the real deal. This is what we see in clinical practice. It's 5 times increased, 5% per year. And in our clinic, before we started this trial, this is where we draw our line in the sand. So if you're monitored all the time with an implantable device, you have an AF episode lasting more than 24 continuous hours, you go on therapy. Now, obviously, if your monitoring period is shorter, if it's a 24-hour Holter, 24 hours out of 24 hours is you're in AFib all the time. So there's different numbers, but when it comes to pacemakers and implanted devices, this is where we see the inflection in risk. For shorter lasting episodes, the risk is really quite small. Just skip over that for the sake of time. Why that's important is we're dealing with an older population. So in my clinic, I'm not sure what the data are here, but in my clinic, the average age of a pacemaker patient is about 77 years. And these patients have risks that are higher in terms of bleeding. So Averroes data, a trial of aspirin versus apixaban in AFib patients. And you can see here, if you're over the age of 75 with either of those two therapies, your bleeding risk is roughly 3 times higher. So we got to a situation where we have short-lasting AFib with a lower risk of stroke, and we're dealing with an older population with a higher risk of bleeding. And this is really where we get to the equipoise issue. If we had a perfect therapy without bleeding risk, of course, we would give it, but we don't have such a thing. We have better anticoagulants now, but they still do have some risk of bleeding that you have to balance. And so really that's the end of the day for this question. Framing this question is, what's the risk, what's the potential benefit of therapy, and what should we do for patients? Now, to make things a little bit more complicated, one of the cool things with pacemakers is we can tell exactly what's going on all the time. So we often order a Holter, a loop monitor, or some type of study to look at patients who have just had a stroke. We think it's caused by a clot, and we want to know, was that atrial fibrillation? Of course, we can never know for sure, right, because we can't go back in time and monitor them before they had the stroke, so we assume that if they have AFib afterwards, that's what caused the stroke. Of course, pacemaker patients are magic. You can go back in time because you just pull up the last 6 months worth of data and see what they were doing. And these are the patients in our ASSERT trial who had stroke. The time of the stroke is the black line down the middle, and the little red bars are how much time they spent in AFib. And these are all the patients that had subclinical atrial fibrillation and stroke. One of the neat things you see is that only about 15% of them have any AFib within the month or month and a half of their stroke. It's quite uncommon that most people that had the subclinical atrial fibrillation and stroke, it was many weeks or months before. So the question is, back to Framingham risk score, is this type of arrhythmia, this short-lasting stuff, is it actually causing the stroke, or is it a marker of vascular risk, just like any other carotid interval thickness or whatever marker you want to use? And this is because these are older patients. So they're 75 plus, they have hypertension, they have diabetes, they have other things. And if you look at the cause of stroke that they have, as best we can, and this is a bit of a shaky science still, but about a quarter of those strokes appear to be cardioembolic. They're big wedge-shaped infarcts when you look at the neuroimaging. But, lacunar stroke is still about a quarter of the patients with subclinical AFib. They're having lacunar strokes. And about 10% are having large artery. They got a big carotid plaque. And so I think one thing we simplify, and this applies to everybody with atrial fibrillation. If you see an older patient with atrial fibrillation, don't forget things like Framingham risk score, statins, blood pressure therapy, because the reality is anticoagulation is a key part of it for patients with atrial fibrillation, but you have to look at the global picture of the patient because, yes, that stroke may have been due to atrial fibrillation, but their next stroke may be a hypertensive bleed. It may be a large artery embolism or plaque rupture. So it is really a mixed bag, and I think we sometimes oversimplify it when we give talks and say that atrial fibrillation causes embolic strokes. The reality is people with atrial fibrillation have all sorts of different strokes, some of which get better with anticoagulants and some of which are best treated other ways. And there's probably the best evidence of this. These are data from the RELY trial, the first NOAC trial. I'll just draw your attention to that line at the bottom. These are the patients who were in a clinical trial. They're well treated, well managed, and they got randomized to the Bigatran 150 BID. So these patients largely took their pills. They came for follow-up. And you can see here, their risk of stroke was about 1% per year. So even if you give an anticoagulant to higher risk individuals, older individuals, and that you're pretty sure they take it, like in the setting of a clinical trial, there's a background rate, right? Because those drugs are wonderful for preventing some types of stroke, but for lacunar strokes, not so good. For intracranial hemorrhage, obviously not so good. But there is a background rate, and so when we're talking about subclinical AF and pacemaker patients, and I'm saying the stroke risk is 1.5%, keep in mind the floor is not zero; it's some low number, but it's typically zero. So I might just shoot through this and show the trial that we're going to do. We're about 2/3 of the way done this trial now. This is called Artesia. These are our pacemaker and ICU patients. They have episodes lasting between 6 minutes and 24 hours. They have risk factors for stroke, age, or typical CHA2DS2-VASc factors, and they're randomized either to aspirin or apixaban. The aspirin is really used because about 70 or 80% of these patients at enrollment are already taking aspirin. Maybe that goes down in light of the spree, but that is the randomization that we worked out for reasons that I can explain later. And we are following them forward to look for stroke and embolism. So really asking the question, does it make sense to treat these patients now when they're just having short little episodes, or do you simply follow them along on a remote monitor or with pacemaker interrogations and treat them if they get more prolonged episodes, more than a day? And this is kind of our, a little captive audience where we have perfect measures of how much atrial fibrillation. They're very compliant with follow-up, and we're really sorting out in the pacemaker world where you draw the line. Because as I'm going to show you, this is a common problem that probably 4 or 5 people in this room have and don't know about. And so this is why we want to sort it out right now. And there's another German study asking essentially the same question. Of course, ours is awesome. So hopefully Canada will finish up. We should finish in first place there. So this is important for me. I actually spend time in the pacemaker clinic. It's a lot of fun. Jen knows how fun it is. It's a really interesting place, but it's only a small part of the world. And really, the big interest in this now is what's happening outside the pacemaker population. Now, the first place we looked were in patients with stroke that appeared to be embolic or cryptogenic stroke in this case. These are the crystal AF patients. So this study was just an observational, it was a randomized trial, but they were just looking. They randomly assigned people to get a Holter. After cryptogenic stroke, about 3% of those people had AF detected. The other group got an implantable monitor, one of these USB-sized devices that goes under the skin for up to 3 years, and they found about 10 times more AFib. About 1/3 of people had AFib. So this is a high-risk group. They just had a cryptogenic stroke, presumed to be embolic, and 30% of them have AFib lasting more than 30 seconds. So the logical thing is, well, we have great treatment that reduces stroke by 2/3 in this population. Let's just dish it out to these patients and see what happens. That was the Navigate-ESUS trial that Bob Hart at our place led with Stuart Connolly. Large population, over 7,000 patients with cryptogenic stroke that we now refer to as ESUS, embolic stroke of unknown source. Half of them got treated with aspirin, that's the standard of therapy. Half of them got rivaroxaban at 15 milligrams a day. Again, the thinking was if 1/3 of them have AFib, we should show some benefit in terms of stroke with treatment. What did they find? Not much. There was no impact on stroke rates, recurrent stroke rates with rivaroxaban compared to aspirin. And the cost of this in a relatively low-risk group compared to in terms of bleeding risk compared to the pacemaker population was that the bleeding risk was doubled. So no benefit on stroke, doubling on bleeding. There's a second ESIS trial that has just come out called Respect ESIS. Also neutral on stroke reduction, although maybe some signal in older individuals over 70 years old. And this was using low dose dabigatran. It was neutral on bleeding. But still no clear, compelling need for this strategy of just anticoagulating people with a cryptogenic or embolic stroke of unknown source. So that surprised me. This was one of two studies that we ran out of Hamilton that came out with their study results within a few weeks of each other, and I totally guessed wrong on what they show. I thought for sure this would be effective, knowing what I know about anticoagulation and AFib, how common it was. And I'm quite convinced, though, that we can't really shine this up and make it positive. Although we do have a third study we're about to take on if people are interested, looking at patients with embolic stroke who have big left atria or lots of PACs in the whole, or maybe there's a subgroup that really do have high burden atrial fibrillation might benefit. But this is pretty neutral as far as study goes. So that was the cryptogenic stroke population. They really didn't benefit as much as we thought, but we also want to look at the broader world. And this is the really important stuff, or the really cool stuff. These are just average older people with typical diseases you might see in a preventive cardiology clinic, for example. There's their age. Hypertension is pretty common, a little bit of heart failure, diabetes. These are patients without any atrial fibrillation, and they had to have atrial enlargement. So you can see there, those atrial numbers are pretty big. Dimensions 4.7, volume 76 mLs. This is kind of the upper quartile of the population in Olmsted County, for example, in Minnesota. There's a large cohort study. So these are bigger. This is the bigger quarter of people. And what we did is we put these little implantable devices in them to see how much atrial fibrillation they would have over the next year. So any takers on that? Patients like this, 256 of them, they're in their early 70s. They have a smattering of typical cardiovascular disease, but they're in the upper quartile for their age, general population. How much AFib do we find? 30%. I'll go with the one number. So it depends how long it takes, how long you score it, but 30% is the correct answer if you're scoring 5 minutes or more. If you look for longer episodes, day in duration, 2.7%, but this is very common stuff. And if you look at the top half of the population, so if their LA volume was over, I think it was 72.5 mLs, their rate was 55% at 1 year. If you're over 78 mLs, atrial volume had an episode of at least 5 minutes. These are adjudicated real atrial fibrillation, not pretend. So this has been kind of what we've seen. There's a variety of trials around the world. You can see them listed there, but most of them will show the same thing. Is if you take an older person with typical cardiovascular disease, give them a monitor, and somewhere between a quarter and a third of people, you'll find AFib within a year. So the question is, does a quarter to a third of the population over 65 need to be on anticoagulant? The answer is probably, if you dial it back to the Navigate example, that was the assumption. You saw the same. Actually, you see more AFib in these patients than you see after cryptogenic stroke, probably because the age is higher by about 10 years. So, but this is very common. It's out there, and it is now not only going to be my problem and my nuisance in the pacemaker clinic, it's going to be here for everybody because of technology. Okay, so who's seen a consult from a home ECG device? Anybody got those in clinic? And Apple hasn't even launched their beast here up north, but it's happened down south, and it's a matter of time before it comes. We have all sorts of tools out there. Blood pressure monitors will pick up irregular pulse now, reported as atrial fibrillation. They're quite good. They're shockingly good and specific at finding atrial fibrillation. The phone-based devices like a live core cardia, we use these. They can pick up atrial fibrillation, the implantables. I haven't shown the watch. This is an older slide, but the watch is here. And I think now this is our problem, right? So if I struggle over 10 minutes of AFib on a pacemaker, what do you guys do with the patient who's taken 7,000 recordings with their alive core at home, and one of them shows something that might be atrial fibrillation? Is that a ticket to lifetime anticoagulation, or is that a ticket to a psychiatry consult? Could be both. all of the above. But the Apple Watch, kudos to Apple. They do actually invest some money in research and have launched a bunch of large cohorts. The downside is they're largely about finding disease. They're not so much about developing strategies to deal with that. The end line of finding the AFib is consult your physician, and that's where you guys come in and have to handle this. So screening recommendations. It's the same US PSTF that Bill talked about earlier that adjudicates this in the US. These are the Europeans, where a pulse check and now the use of a single handheld in an opportunistic screening way has been advocated. If you use simple tools like this, you do find a lot of atrial fibrillation. So this is a small Canadian study of a few thousand people we did here and in Alberta. Community pharmacy. These are people not even going to the doctor. They're going to the pharmacist for drugs or magazines or whatever you get there these days. Over 65, about 2% of these people walking off the street with a single handheld had atrial fibrillation detected. And if we broke it down to the 85 plus group, about 8% of them were in atrial fibrillation at that moment. Now, it's obviously a convenient sample. It's not perfectly population-based, but I'll show you that in a second. But that's not inconsequential. To my earlier point about other risk factors of those people, 50% of them had blood pressures more than 140/90, and this is with an actual trained person using CHEP guidelines to measure the blood pressure, not just slap it on in the pharmacy. This was a proper blood pressure, very high prevalence. And so our conclusion was there could be some value with the screening there, and this could be cost effective. We'll skip that and go to this. Now this is epidemiology. This is a Swedish study. These are patients aged 75 and 76 in two large regions of Sweden. They were called up out of a phone book. 62% of everybody invited agreed to participate in the study. So they call them in the winter when it's dark and there's nothing going on, and 62% of people selected based on their age alone agreed to be screened. They did 2 ECG recordings using a phone device, 2 ECG recordings a day for 2 weeks. And this is what they found. About 3% of patients had newly diagnosed AFib picked up by that method. Now, these are older people, 75, 76, and that's a big driver of AF detection. Another 2% of people had it diagnosed. They had it diagnosed before, but they weren't on treatment even in Sweden. So their conclusion was about 5% of people you would turn on something that was actionable and could lead to better stroke prevention. And this is where they do their economics and say this is likely to be cost effective. 4,000 euro per quality. So that is, those are interesting data. When you're talking about screening very old people, you're going to find a lot of atrial fibrillation. The question is more intensive screening worthwhile? And some studies have been done using more intensive handheld devices or even patch monitors. You find more atrial fibrillation, but it tends to be shorter lasting and probably lower burden. Like if I do this once with an ECG machine, I'm in AFib. If you knew the truth, my average burden over the course of a year must be pretty high. But if you put a watch on me and it's intermittently doing this every day for a year and you hit one set of the year, that's probably a low burden. And I think that is important. And I think the pacemaker trials will help us understand when we intervene and when we don't intervene and give some answers that unfortunately, Apple has not been able to provide with response to their watch being positive. Again, I'm strongly advocating if any screening is done, screening has to be integrated. I mean, you can't ask a family doc to now add 7 more things to cram into that limited visit. I think as best as we can, you combine this with other things like hypertension screening. The Dutch do it with the flu vax, so you have a 10 to 15 minute mandatory waiting period after you get a flu vaccine. Most places, Ontario and Holland, the same. And so they say, okay, sit over in a chair and instead of twiddling your thumbs, hold this in your thumbs. And they screen for AFib at their annual flu campaign. I think those are clever things if you want to do it. It may very well work because we do have effective stroke prevention therapies, not only anticoagulants, but blood pressure reduction as well in this population. We have a few large trials that are ongoing, Stroke Stop, large UK RCT, and we may announce in the next couple of weeks a large North American randomized trial looking at screening for atrial fibrillation in primary care. So this is what's required. Right now, the USPSTF, that same organization that Bill talked about, does not recommend any form of screening right now based on lack of evidence. I think screening, how to understand where they come from. They're a large government organization. The world moves when they make a statement. I think screening has to be kept separate from what Dave Sackett used to call opportunistic case finding. So that's the person's in your office, they're getting a checkup for whatever, you feel their pulse, you have them hold a device. That's opportunistic. It's not ringing up everybody on the street and say, come in, you have to have your screening test done. So I think there's a lot more acceptance if you look globally at guidelines for case finding. If people are in there for something else, there is value in higher risk people to screen or to case find rather. But it is certainly a big contentious issue, and there's a lot of disagreements amongst agencies around the world right now on what we should be doing, despite the fact that we have good drugs and that we have really interesting tools to screen. So there's just a few of the people that are doing this type of research around the world. I just want to jump to a few last interesting things. And maybe we can get back into this whole COMPASS thing. It's kind of relevant to the first conversation we had today about antiplatelet therapy. These were the results of COMPASS. Obviously, in a higher risk group, patients, the combination therapy with rivaroxaban at 2.5 BID plus aspirin hit the primary outcome. It was the most successful of the 3-arm study. If you break down what actually was reduced in that primary outcome, it's quite interesting that stroke was reduced by 42% in that population. And so again, the question is, do you screen looking for the atrial fibrillation, or is that intervention used in COMPASS in higher risk people effective for looking at stroke? And Bob Hart's just presented another paper on this. It was all types of stroke. Even lacunar stroke was lower with this treatment, which is really, to my mind, the first antithrombotic therapy that's ever hit on lacunar stroke in terms of reduction. Obviously, it's a one of, but interesting observation. And here's the other thing. Again, I like to look at the whole patient, and I think that's something that this group here does very well. We always think subclinical atrial fibrillation, stroke, right? That's the important thing to cover off. What's the leading cause of death in a person with atrial fibrillation? Your patient has AFib today, they're dead in 6 months. What do they die from? Heart failure. They get admitted to hospital 6 months later. What do they come in with? Come in with heart failure. This is a massively underappreciated fact that patients with atrial fibrillation, whether it's HFrEF or HFpEF, they're going to have trouble with heart failure. It's 3 to 4 to 1 compared to stroke in terms of cause of death now in our global surveys. We looked at these same pacemaker patients and looked at if they developed long-lasting episodes of a subclinical AFib over 24 hours here, what was the prediction for heart failure, hospitalization, or death? And remember, stroke, it was 2.5 times predictive. This was 4.5 times predictive. It was almost twice as good at predicting heart failure decompensation as it was predicting stroke. And it's a much more common event in these patients. So again, I think when you see your patient with newly diagnosed atrial fibrillation, who's 50, got a borderline blood pressure, a little bit of extra weight, maybe some sleep apnea, you got to start going down the heart failure prevention road as well, getting that blood pressure meticulously controlled and doing what we do for heart failure. Unfortunately, heart failure with preserved ejection fraction, we don't have a lot of super effective therapies, but there's going to be a lot more coming on this in the future. So it's not all about stroke. It's about global cardiovascular risk, and it's about heart failure as well. So I'd sum that up by saying a few things. First of all, this is very common. If you have a good enough tool and you're looking at an older population with typical cardiovascular disease, you will find a lot of atrial fibrillation. If you want a number, about 1/3 of people will have atrial fibrillation. I don't think everybody needs to be treated at this point, but we are going to explore over the next few years where that line in the sand might lie. I'll give a little story on this. I went to see a consultation to put in an implantable device in someone's left atrial appendage for this woman who had atrial fibrillation for 6 years. During the past 6 years, she was on warfarin because she had renal insufficiency. She had been admitted to hospital 7 times with GI bleeds, had received about 20 units of blood over 7 years, and they said, well, you have a better option than warfarin. Can't take DOACs because their GFR is like 28, and can you put a device in? So, okay, let's look and see. Let's pull out our chart. Her diagnosis of atrial fibrillation was based on a 7-year Holter where she was in an irregular atrial rhythm for 26 seconds. She'd had maybe 30 monitors over the course of that next, not 30, but 20, and that was it. Never a clinical presentation. She had 26 seconds of atrial, I wouldn't even call it atrial fib at 26 seconds. And that's, she'd gone through this whole thing. So I think when we diagnose this, we have to be a little bit more thoughtful, right? We don't do open hearts for 20% stenosis. But we consider, ask my neurologist colleague, how much atrial fibrillation do you need to treat with anticoagulant after a stroke? Answer, 3 beats. Okay, but that's extreme. And I don't have a good answer for you where that threshold lies. I think that the more you have of it, the higher the risk goes. But right now, we have to have a few trials, which are unfortunately going to wind up in the next couple of years, which will give us some better signposts about where to treat. And then finally, I think you can't forget about heart failure in your atrial fibrillation patient, whether it's someone who's picked up on a screening test or whether it's someone who walks in the traditional method. Heart failure and atrial fibrillation are a couple, they go together, and you have to look out for both. So with that, what do we do for her? We put her in a clinical trial. That's always the cheesy Hamilton answer, right? But, I think part of the thing that we should do is when you don't know, just like our colleague down under, when you don't know, say you don't know. We have to have guideposts, so I don't like wimpy editorials either. Where we draw our lines, over 24 hours, you get treated with an anticoagulant. If you've had a recent and temporally associated embolic appearing stroke, you get anticoagulants. And then, in the absence of a trial, the higher the CHA2DS2-VASc score, the longer the episode, that tends to go towards treatment. Shorter episodes, lower CHA2DS2-VASc score, that tends to go towards non-treatment. And then, bleeding risk assessment modulates everything. So first go around, no problem. After your 7th blood transfusion for GI bleeding, for a short-lasting subclinical atrial fibrillation, we'll probably throw in the towel there. So I think it's kind of a fuzzy recommendation, but that's how we practice medicine, sense and rough ideas. So leave it at that. Hopefully you have some questions, and we can go from there. Right?
Should we stop screening for AFib and criticality stroke?
Yeah, so the question was, should we stop screening? I think, if anything, the negative or neutral results of the 2 post-stroke trials have kind of led to resurgence in screening after stroke. We used to, if that had worked, the neurologist would have been very efficient because you could just treat people with anticoagulants, send them home, and no further thinking. I think with the neutral results, people said, okay, we should be again looking for the atrial fibrillation. That's the practicality. I'm not sure we should stop screening. I don't think we fully understand. I think.
The treatment didn't seem to help.
Yeah, but perhaps 2/3 of the people. Yeah. So the question was, the treatment with an anticoagulant didn't seem to help people in the Navigate and Respect-ESUS trials. Again, it could have been 2 things. One, 2/3 of the people didn't have atrial fibrillation, so you're treating 2/3 of the people who didn't have the condition. So the screeners would say, well, if you just boiled it down to the people that really had the condition, the AFib, you would have a benefit. And that's what our 3rd in the series of the trials is going to do. We're looking at people with big LAs, more than 4.7 centimeters. That is, in my mind, one of the best. Left atrial volume is like the best way to kind of hone in on atrial fibrillation. It's a very good test, and it can really tip your hand for atrial fibrillation. So I don't think it's killed screening at all. I think it's actually made it more, and I think there's still some hope that some group of those patients will actually benefit.
So at this point in time, if we see the congenital patients on a monitor, we should treat them.
Yeah, I think so. And again, I haven't gone over specific thresholds. We've just written up a modeling paper. What that number is on a 24-hour Holter, for example, it's a few minutes. It's not 24 hours, like a few minutes worth of AFib. I generally don't even call things less than 30 seconds. I call them atrial tachycardias. I don't call them atrial fibrillation. We have that Holter reporting consensus, and I think that's fair. But it doesn't take a lot on a 24-hour Holter in a post-stroke patient to want to do that. That's my university looking for money. My med school, serious.
So
I think the stroke neurologist would like us to do a Holter monitor if you don't find anything, then 14 days. And,
Yeah, the US record is 30 days.
you concur with that, and how much atrial fib you need to say on a 14-day monitor to say, we found that we're treating?
Yeah, so the question was, what duration of monitoring would you order after stroke, and how much atrial fibrillation would trigger therapy, which I think is a great practical question. I'll preface this by saying it depends on where you work, right? In Ontario, we have access to prolonged cardiac monitoring. If you work in other provinces, Alberta, for example, you get 24-hour Holter monitor, which you can repeat multiple times perhaps, but you don't have access in half of the provinces in Canada, you don't have access to other prolonged monitoring. So let's pretend we're in Ontario, because we are. 24-hour followed by, there's some logic to that. Some people prefer the in-hospital telemetry post-stroke, and they count that as their monitoring. Our group typically does 2 weeks. 30 days is another recommendation. And again, I think it's a density function. On a 24-hour Holter, if I could stick my neck out and just give numbers, keep in mind they're not evidence-based, they're eminence-based, I guess you'd say. Couple minutes on a 24-hour Holter, 10 minutes on an extended monitor, but it doesn't have to be a whole lot because you're still taking a relatively simple snapshot. The final caveat is it depends on how often you order it, right? If I order 26 2-week monitors, that's a year, and it's the same as having my pacemaker patient. So it's one of those things. The more you order it, the less the threshold moves up, right? But it's only a few minutes on a 24-hour Holter monitor.
So if I just comment, John, just on this subject, I was going to actually present this to you. That's a good segue from what John said. So recently we had a woman in her 50s who, late 50s, who was hypertensive, modest LA dilatation, who had a cryptogenic stroke, and she had 3 separate 14-day Holters. In the first Holter, she had no atrial fibrillation. The second Holter, she had under a minute. The third Holter, she had 17 hours. Maybe I should have anticoagulated after the second Holter, but I didn't, but I certainly did after the third. I don't know anybody's thoughts on that, but she clearly had an unexplained stroke, ischemic stroke, and it was the third 14-day Holter where a substantial burden of atrial fibrillation was demonstrated. So,
without
the more you look, the more you find. I mean, that's just the way it is.
And without knowing, any better, I would have probably done the same thing. I would have probably thought the second one was too little, but I probably would have said it's enough to look for more.
Yeah, and that's exactly what was our thinking was. So.
Yes,
Jay?
In the device patient population, can we put any weight on cumulative AF burden? So we may have, a device that stores 30 episodes, or 300 episodes. Of the 30 episodes you can look at, they're appropriate, they're atrial fibrillation, but they're minutes and there's nothing that's long. But they have an elevated burden.
Yeah, that's an excellent question. So the question was, can you put any faith in the cumulative burden of atrial fibrillation as a metric on a pacemaker or an implantable defibrillator? The answer is yes. You can place quite a lot if you're comparing apples to apples. So same device, same algorithm for determining burden. Now, in some of our studies, we went with longest episode duration instead of burden. Not that we thought it was better, but we're mixing and matching different companies. And, a burden measurement on company A is not the same as a burden measurement on company B, first of all. Second of all, for the episodes that are less than 6 minutes, back in the early 2000s when we did that study with the non-Medtronic devices, for less than 6-minute episode, only half of them were real when we manually reviewed them. So the false positive rate was 50% for short episodes. When you got over 6 hours, the false positive rate was 3%. And so the longer episodes tended to be real, and the shorter episodes, unless you reviewed them, were uncertain. And so the burden calculators could get filled up with a lot of short episodes of garbage, and the patient could say they had 3% burden, and it was all junk. And so that's why we went with long duration. But I'd say, some of the modern devices, if you're comparing device to device, burden calculators have become quite good.
Is there a burden when you're confident that the episodes that are stored are appropriate?
Yeah, I mean, again, if you look back to the trends, a daily burden of 5.5 hours was where they saw the risk of stroke go up. right? That's so below 5.5 hours, they could not measure a stroke risk increase. And so it was actually quite a bit of burden. But again, to the point we've been discussing, that's with continuous monitoring for many cases for years. And so you have to find quite a bit when you're looking every day for a year. Right, it's like when I went to visit my parents in Palm Springs, we went golfing a couple of weeks ago for my dad's birthday. It was raining. And if I went there, I said, well, Palm Springs is this super rainy place, right? Because I hit there once and it was raining. But if you went there every day, you would realize it's a desert, right?
John?
In what circumstances do you move on to implantable devices for monitoring? And how are you paying for them? If you can't get funding for, it's not in the pacemaker budget to put in.
Yeah, so when do we do devices and how do we, implantable monitors, and how do we pay for them since they're not directly funded by the ministry? So 2 practical questions. We do about 15 to 20 a year, mostly for syncope. We selectively use them following cryptogenic stroke, but I would say our neurologists mostly use non-implantable technology, patch monitors and extended loop monitors, for example. We typically, when we make an RFP, there's certain bundling that gets done, and we usually ask the vendors to bundle a couple dozen of these in, and that's more or less what we use. But in Canada, most places have a fairly modest use of these devices. American centers, these things sell like hotcakes. Like, this is a multi-billion-dollar industry south of the border for implantable monitors.
And it really is better technology for picking up the index.
Implantables are good. Again, we use surrogates to screen, and again, I think if you do a Holter and an echo for starters, you can kind of cone it in on who you might be more likely to target. If the patient's got an LA volume of 90 mLs and they have 10,000 PACs in 24 hours, that's a high likelihood candidate. Maybe they get a loop, maybe they get another patch or something.
And on the same note, we use quite a bit of home remote monitoring in pacemakers. And
Yeah.
I know a lot of people don't monitor pacemakers remotely, but we use it for atrial fib. That's our purpose.
Yes, absolutely. So so we have home monitoring, and Jen was asking, should we use this for these patients? It's a great concept. It's a purely money thing. Like, again, an injectable Link device is tiny. It's smaller than the USB key. It's in there for 3 to 4 years, and you can monitor it daily from the patient's bedside. Really good technology. Price points $3,000 or $4,000. So again, in managed care settings south of the border, they use them. In our funding model up here, we use them extremely selectively.
Just to interrupt for a sec. So anybody on the web, if they want to send a question in, please do so. We're probably going to just be on for 3 or 4 more minutes. So if you have a question, please send it in. John.
You mentioned embolic stroke. How do you know it's an embolic stroke? Are your radiologists saying this is a typical embolic event? I'm much more primitive. I see them and they've had a stroke, and I really don't know the mechanism often.
Yeah, so the question is, how do you know when a stroke is embolic? If you ask the world experts on this, they'll give you an answer, but it is a bit of a dark art, and they're okay good at this, but they're not perfect. You see multiple cortically based wedge-shaped infarcts bilaterally in the same patient. That's probably an embolism.
Okay.
You see a typical little punctate lesion in the basal ganglia. That's probably a lacunar, but there's huge overlap. And again, I would stand back from it a little bit and say that the reality is these patients have a variety of different stroke mechanisms. It's an imperfect science. And in pacemaker patients especially, because up until recently, we couldn't do MRIs in many of the patients. Now we can, so we're getting a lot more data from our new trials.
Just to make a comment that I overlooked the COMPASS finding that lacunar stroke was reduced too, so which changes the whole kind of concept of what those even are.
Yeah, you probably haven't seen it because it was just presented a few weeks ago.
Okay.
So you're excused.
Oh, thank you. Yeah, that took me by surprise, I must say.
Yeah, because we had, aspirin trial, clopidogrel trial, the SP cubed, and nothing really seemed to move the needle on lacunar stroke from an antithrombotic point of view.
Okay, Don, is there anything coming in?
There's not.
Okay. So, any last questions for John? Do you know?
Yeah, 24 hour. Like I've always ordered 480. What's the point? Is 24 hours just as good?
No. The longer you look, the more you find.
Okay, yeah, I just wanted to.
Simple as that.
24 hours.
Yeah. So our routine now is to do up to 30 days in cryptogenic stroke.
If you go back here, this is with a perfect monitor. This is a 365-day Holter. And to Bill's point, that's the curve, right? You're front loaded, but you're still steeply picking up new cases at 6 months. It's getting, it still doesn't flatten out till about a year and a half after you start recording.
What percentage of the people that have congestive heart failure, atrial fibrosis? I have tons of patients, but I haven't seen too many with the congestive heart failure, atrial fibrosis patients.
Oh, they're out there. Yeah, so the question is, what percentage of patients with either heart failure have atrial fibrillation or atrial fibrillation have heart failure? Yeah, no, it's the heart failure patients, when we looked at in our implantable monitor study, they weren't that different than just older people, but a third to 40% of them will have atrial fibrillation if you look continuously for long enough. Does that mean they need to be treated? Again, I'm saying no, because we don't know. This is subclinical stuff that's never been studied in a treatment trial. This stuff would have all gone unnoticed if you didn't have implantable monitors, but we're in a new era now where we have pacemakers, implantable devices, patches, watches. Everybody's getting monitored, and the question is, does everybody need to be treated? Maybe yes, maybe no. Give some general ideas about where the thresholds are now, but hopefully we can give some clearer ideas that come back to tell you in 2 to 3 years.
Is that your invitation? You just
trolling
for an invitation for your videos? That's good. So, Jeff, I want to thank you for coming. I think this presentation was quite interesting and inspiring to all of us tonight who are dealing with us on a daily basis, and gave us some good insights. Really appreciate you coming.
Thanks for having me. Thanks.
And for those who want to stick around for a bit of music, you're welcome. Out there. It's out there. Okay. Jen says it's out there. They've strung up the major sharpers to do lectures. So.